Welcome back to the BHS channel. This is video 2.1, and this video will talk about the major electrolytes. So we'll talk about sodium, potassium, and chloride. These are three electrolytes that are commonly measured, routinely measured in the clinical setting. And as we discussed previously, sodium is also closely related to the osmolality test. So all of these electrolytes, you can see, are charged, either positively charged, what we call cations, or negatively charged, what we call as anions. And because they are charged, water molecules will surround them very well. They dissolve very well in water, and therefore these electrolytes are found in the water part of cells as well as the water part of your bloodstream. In order to understand the clinical aspects of sodium, potassium, and chloride, we need to first look at these special type of transport proteins that are found in all cell types, called the sodium-potassium ATPase pumps, or simply sodium-potassium pumps. Now, these pumps suggest transport proteins that utilize energy, ATP energy. So these sodium-potassium pumps found in the cell can use quite a bit of energy, sometimes as much as 30 to 60% of all the cell's total energy. And what these pumps do is basically they pump 3 sodiums out of the cell in exchange for 2 potassiums into the cell. Okay, so basically the net is the pumps are basically removing a sodium particle out of the cell, continuously removing a sodium particle out of the cell. So this net transfer of one net positive charge, this sodium, to the cell's exterior for each rotation cycle of the pump leads to an accumulation of positive charge outside, and that leads to basically a membrane potential of minus, let's say, 70 millivolts across the plasma membrane. So besides the membrane potential, you can see the potassium inside the cell will be very high compared to the outside because of the sodium-potassium pumps, while the opposite is true for sodium. Sodium outside the cell will be very high. Sodium in the cell, inside the cell, will be very low. So basically, you can see there's a concentration difference. High sodium outside means the sodium will want to try to get into the cell because there's a high sodium outside, low sodium inside. So if you can find an open sodium protein, sodium transport protein, it will try to do that just by the laws of diffusion. Similarly, potassium is high inside and low outside. So if the potassium could find an open protein that will allow it to go through, it will try to get out. So that's the potassium gradient. Okay, so we have a sodium, very important sodium gradient that we'll talk about in a few seconds, and then we have this membrane potential. And all this is happening in cells because of these sodium-potassium pumps that are using energy to kick out sodium in exchange for potassium. So why do these cells have these sodium-potassium pumps? There are several reasons. Let's look at three important ones. One is these pumps maintain the intracellular osmolarity. We talked about osmolarity in the previous videos. So inside the cell, the concentrations of proteins and other large macromolecules is very large, is very high compared to the extracellular fluid. Okay, so if nothing is done about this high osmolarity inside is going to cause water to enter the cells. So by pumping sodium out, remember osmolarity doesn't care about particles, doesn't care about the nature of particles, it just cares about the number of particles. It doesn't matter whether it's sodium or potassium or whatever it is. So by pumping net sodium out, these pumps are helping to maintain the osmolarity inside the cell. And then we have a lot of things are happening inside the cell. One of the things we'll talk about under metabolism is one of the most important things cells have to do is they have to continuously generate ATP. Okay, and to generate ATP, you'll see that few molecules are broken down into smaller chemicals. So for example, a glycogen, which is a very important fuel in cells, is broken down into many glucose molecules. Okay, hundreds of glucose molecules. Then the glucose molecules are further broken down into pyruvate molecules. Other fuels like fatty acids, along one molecule of fatty acids is broken down to many smaller molecules. Okay, so basically during this metabolism, you can see a lot of particles are being formed, and so that is going to temporarily increase the osmolarity, intracellular osmolarity. And again, if these pumps were not working, then you would see water entering the cell and the cell swelling, gets swollen. And that's one of the earliest signs of a cell damage that we see in pathology is cell swelling. And once the cell swells, then all the functions or a lot of the functions of the cell is going to be affected. Okay, so these pumps are very important by kicking the sodium out, kicking a particle out all the time. It's helping to maintain the intracellular osmolarity to prevent water entering the cell. Another very important function of these pumps is the transport of chemicals against their concentration gradient. So chemicals move in and out of cells by a process called diffusion. That's a process that doesn't require energy. So basically a chemical will go from a high concentration. A diffusion occurs because there's a higher concentration of a chemical on one side and then a lower concentration on the other side. So this is called a favorable concentration gradient. Okay, difference in concentration, high here, low here, then the chemical is going to go this direction. Okay, as long as there is some transport protein or a way to enter the cell. Similarly, if there's a reverse, if it's high inside and low outside, then the chemical tends to go the other direction. Okay, so chemicals basically are traveling by diffusion, and diffusion is always high concentration to low concentration. Okay, so movement of a chemical from in the other direction. Can a chemical go, let's say, here's a high concentration, low concentration. Can a chemical from low concentration go to a high concentration? That's an unfavorable concentration gradient. Okay, now that cannot happen unless there is energy. Unless there's energy available to drive this process. Okay, so movement of a chemical from lower concentration to higher concentration, that is against its concentration gradient, or what we call the unfavorable concentration gradient, requires energy. So chemical pumps actually use ATP energy to carry out such transport of chemicals across cells. Okay, so let's see how these sodium-potassium pumps help in taking things from a lower concentration to a higher concentration. Okay, so because of the sodium-potassium pumps, we saw there is about 140 millimolar concentration of sodium outside, about maybe 10 millimolar concentration of sodium inside the cell. Okay, so there is a sodium gradient. Because of these pumps, there is a sodium gradient, which is sort of and this gradient was formed because of the energy used by the pump. So sodium gradient is sort of a energy. It's a sort of a stored energy. Okay, it's a form of a stored energy. So due to this gradient, sodium is going to try to enter the cell. Okay, favorable for sodium. It wants to enter the cell. So let's say if the cell has a lot of chemical X, there's a lot of chemical X inside the cell, but there's very little X outside the cell. And the cell wants this chemical X, whatever this chemical is. Okay, how is it going to do that? Well, one way it's going to do that is use transport proteins called sodium co-transporters. Okay, so it couples the entry of sodium, which is favorable, sodium wants to get in, to the entry of X, which is unfavorable, according to the concentration gradient. Okay, so by using these sodium co-transporter proteins, it uses the stored energy of the sodium gradient to bring any chemical X from a low concentration to a high concentration. So let's look at a few examples. So let's say during digestion, there's this enterocyte. Enterocytes in the small intestine, they absorb a lot of chemicals. Okay, the enterocyte, for example, might use a sodium amino acid co-transporter to bring in amino acids into the cell and eventually into the bloodstream. So although the amino acid concentration in the cell increases as more and more amino acids come into the cell from your diet, it doesn't matter because the sodium gradient is continuously allowing the amino acids to enter against its concentration gradient. Okay, so in that case, the transport protein called sodium amino acid co-transporters are very useful to make sure that we absorb all the amino acids, most of the amino acids, into our bloodstream from our diet. And same thing happens for glucose. There's a sodium glucose co-transporter protein that uses a sodium gradient to bring the glucose into the enterocyte and then eventually out into the bloodstream. Although the glucose concentration gradient might be unfavorable after absorbing more and more glucose. So that's one example of how these sodium co-transporter proteins help the digestive system to absorb essential nutrients. We see a similar strategy used by the kidneys. Okay, similarly, the tubules are lined by these special cells, tubular cells, and they have all kinds of sodium glucose co-transporter proteins, sodium amino acid co-transporter proteins, and so on, to make sure that we reabsorb. Okay, that's why we call this reabsorption. Kidneys reabsorb because the chemicals were already absorbed once in the digestive system. Now we are reabsorbing essential chemicals that are essential. We don't want these chemicals to be lost into the urine, such as glucose is very essential because it provides energy. The amino acids are very essential. So essential chemicals are reabsorbed. And again, as they are reabsorbed into the tubular cells, the concentration increases, and at some point the concentration of the amino acid or the glucose is unfavorable. But once again, by using indirectly the stored energy of the sodium gradient, these cells are able to reabsorb chemicals in spite of their unfavorable concentration gradients. So maintaining osmolarity inside the cell is one important use of these pumps. Transporting chemicals against their concentration gradients, another use. And then we have another example here, and that is related to the membrane potential. Because of the differences in concentrations of sodium, potassium, eventually chloride and other ions, there is a membrane potential developed across cells. And this membrane potential has a lot of useful applications. So for example, if this cell was a neuron, then what it would do is there's a certain potential, and neurons have a lot of special transport proteins that can transport chloride or sodium or potassium. Okay, so it's all kinds of transport proteins, and these transport proteins can open and close and very quickly, and therefore cause changes in membrane potential, very rapid changes in membrane potential. Okay, and because of these changes in membrane potential, that is what an action potential is. Action potential, and that's the function of neurons, is they transmit information from one neuron to another through the changes in membrane potential, what we call nerve impulses. These are basically due to changes in membrane potential. Okay, so that's a very important role for neurons. The ATP pumps, the sodium-potassium ATP pumps, help neurons do their work, which is transmitting information. Okay, so changes in membrane potential are also very important, which we'll see in future videos. They influence calcium channels too. Calcium channels. Okay, calcium channel. Calcium is a very important intracellular signal. So, for example, in beta cells of the pancreas, if they secrete insulin, calcium channels open based on the membrane potential, and that helps the cells secrete insulin, which we shall see in another video. Okay, similarly, in neurons, they have vesicles with neurotransmitters, and which are stored in these vesicles, and the opening of calcium channels brings in more calcium into the inside of the cell of the neuron, and then that helps these neurotransmitters release or secretion out of the cell. Okay, similarly, calcium affects skeletal muscle, smooth muscle, cardiac muscle contraction, and so on. Okay, so these sodium-potassium pumps play a very important role in physiology as well as pathology. And you can see why they are important to cells. So let's look at some of the lab tests related to electrolytes. So of course we measure chloride, potassium, sodium. Okay, so we have all kinds of, these are the three most common electrolytes that we measure. Osmolality is related to sodium. We talked about this previously. And then there's a new test here that we haven't talked about. And this is the test that we call anion gap. Anion gap. AG, or sometimes we call it AG or AGAP. Anion gap. So anion gap is a useful test to assess the acid-base status. One of the uses of this test is to evaluate the acid-base status of a patient. Okay, and we'll see what acid-base, we'll talk about acid-base status, acid-base processes that happen in humans. Basically, acid, remember, is H+, is a very, very important chemical in the body that affects almost everything. Okay, so pH, we measure this H+ by pH. And humans have to maintain their blood pH, for example, between 7.35 to 7.45. So maintaining this pH is so critical for survival that the anion gap test helps us indirectly in assessing this acid-base status. So according to the principles of electrical neutrality, which means the number of positive ions, okay, number of positive ions, what we call cations, should be equal to the number of negative ions or anions in the serum or any body compartment. Okay, so we have a certain compartment, positive and negative charge must always be equal. You cannot have a positive charge by itself without a negative charge, or negative charge by itself without a positive charge. Okay, so in routinely, there are only certain serum ions that are measured. Okay, so so the value that we call anion gap may be obtained from these routine serum values for the major electrolytes. So the anion gap is basically this formula here. Anion gap is equal to the measured major serum cations, the most important being sodium, which is routinely done, minus the measured major serum anions. And the two that are commonly measured, routinely measured, are chloride and bicarbonate. Okay, so sodium is the most common cation measured, routinely measured, very easy to measure that, labs do that all the time. And chloride and bicarbonate are the anions that are commonly measured. So besides sodium, which is routinely measured, of course our serum has many other cations. For example, potassium, then there's calcium, there's magnesium, and then there are also proteins that have a positive charge. We call these cationic proteins. And these are examples of these are the some of the immunoglobulins. Some of the antibodies tend to have a net positive charge, and we'll talk about these charges on proteins later under proteins. Okay, so these are some of the unmeasured or not routinely measured. They're not routinely measured. And then we have, besides chloride and bicarbonate, we have other anions too that are not often measured. Phosphate or phosphorus. Okay, phosphorus or phosphate. Sometimes the test is called phosphate or sometimes it's called phosphorus. The actual technique of measuring is phosphorus, but what we are measuring is phosphate. And then there's sulfate. Okay, sulfate. There's sulfate. And then, of course, there is anionic proteins. Proteins that have a net negative charge are probably the most common, the most abundant in your blood is albumin. Okay, albumin. So these are the some of the unmeasured. Okay, and you can see these don't appear in this formula here. So the only thing we use in this formula is sodium chloride and bicarbonate. Okay, so the reference range for A gap or anion gap is you can see here around 3 to 15 millimole or millimoles per liter. And that's because that means a positive number here means the amount of this is greater than the amount of these anions. The amount of cations is greater than anions. And that's why you see a positive number between 3 and 15. Okay, so let's look at, let's plug in these numbers for this patient here. If we do that, the sodium here, let's look at sodium is 142. Chloride, let's look at chloride. For this day is 109. And then bicarbonate for this person was 24. We calculate that, comes out to be reference range, in a reference range of 9 millimoles per liter. And that's how we measure anion gap, okay, by using a simple formula. So let's see some of the uses of the anion gap. So let's first look at increase anion gap. So let's look at some examples. Let's say there was a very high phosphate in the serum of this patient. Since phosphate is negatively charged, that's going to reduce the amount of chloride and bicarbonate, which are also negatively charged, to maintain the total number of negative charges. Okay, so because of its phosphate, this number here, chloride plus bicarbonate, decreases. And that is going, because this number has gone down, sodium minus this number, this value is going to, the anion gap is going to increase. Okay, so basically the presence of any unmeasured anions will decrease chloride and bicarbonate and therefore lead to an increased anion gap. Okay, so let's look at some conditions that do this. So let's say there is a condition called alkalosis. Basically, your blood pH or your body pH is going up. Okay, so there's an increase in the pH. Now, one of the things we'll see later is when you increase the pH and you have a protein like albumin, okay, So when you increase the pH, it increases the negative charge on the albumin, decreases the positive charge. You see, proteins can have positive and negative charges, and we'll talk about this later. But in this case, increase in pH is going to increase the negative charge on the albumin. Okay, so because now the albumin has become has increased in negative charges, this chloride and bicarbonate is going to go down. Okay, this is going to go down. So in alkalosis, which makes albumin increases negative charges, this chloride bicarbonate is going to go down, and this anion gap is going to increase. Okay, so alkalosis, we'll talk about this acid-base status in a future video. But when your body pH goes up, your proteins tend to have more negative charges compared to positive charges. The increase in negative charges is going to lower the chloride and bicarbonate. Sodium is not changed, so the net result is this number anion gap increases. And of course, another reason for an increased anion gap is what we talked about earlier. Okay, if there is any increase in anions that are not measured, so phosphate, sulfate, okay, or any other anion. So if any other anions in your serum increases, in your blood increases, then that's going to decrease this value, and your anion gap is therefore going to increase. Okay, now let's look at some condition that decreases the anion gap. Okay, some clinical cases, conditions that decreases the anion gap. Okay, so one is, let's see, if your albumin goes down, okay, hypoalbuminemia, low albumin. Now, albumin normally is a anionic. If the pH is 7.4, then it's an anionic protein. Okay, so if the albumin concentration goes down, what's going to happen, right? It's going to result in a low anion gap. Okay, why that happens is because if your albumin goes down, then these ones will go up. Okay, it will increase this. This remains the same. And so your anion gap now goes down. Okay, so your anion gap will go down. So hypoalbuminemia, which can be caused to many diseases, especially kidney problems, or if the liver is not making enough albumin, that can result in a low or decreased anion gap. Okay, so one reason for decrease in anion gap is because there is a decrease in unmeasured serum anions. Unmeasured. So if any serum anions that are unmeasured, if there is a decrease, that is going to increase this chloride bicarbonate, and that's going to result in a decreased anion gap. So another reason for a decreased anion gap, besides decreasing this unmeasured anions, is to actually increase serum cations. What if there was some cations, some X cations that increased? Okay, there was some increased cations. So let's say potassium increased, or your calcium increased, or your magnesium increased. So any of these cations that increases is going to make your sodium go down. Okay, so your sodium goes down. So another way for a decreased anion gap, so let me erase this. So another way to get a decreased anion gap, decrease this number, is to decrease your sodium. Okay, and sodium will decrease if any of your other cation increases. Okay, whether it's potassium or calcium or magnesium or even cationic protein. Okay, cationic protein. As I mentioned earlier, there are cationic proteins such as the immunoglobulins. Okay, immunoglobulins. Okay, so there's a disease, for example, called multiple myeloma. It's a cancer, and that produces a certain protein that tends to be positively charged. Okay, so the increase in any cation is going to reduce the sodium to maintain electrical neutrality, and that's going to lead to a decreased anion gap. Okay, so there are quite a few important, you can see, tests for electrolytes. Just to summarize, the sodium-potassium chloride tests are done very, very commonly. Osmolarity we talked about previously, very closely related to sodium. And then we just saw that the anion gap can give clinicians a lot of useful information. So before we leave this topic of electrolytes, I would like to talk about two conditions which are related to the lab. So one is when we analyze serum samples that have very high lipids, okay, very high concentration of lipids. We see that, for example, in pancreatitis, high lipids. We see that, for example, in diabetes. Or if the blood sample has very high proteins. And you see that again in that cancer, it's called multiple myeloma, which is cancer cells secrete so much of that paraprotein, that immunoglobulin, that their protein levels in the body becomes very high. So that leads to can lead to a falsely low electrolyte values. Okay, low electrolyte values. Why does that happen? So in a normal case, so here's a normal case, okay, where the lipids and the proteins are just normal. When you take a blood sample, let's say I collected, just to give you an idea, let's say this sample that we are going to collect and we're going to inject eventually into a machine, an analyzer. So let's say you thought you took 100 microliters, okay, which is fine. That's exactly what goes into the machine, 100 microliters. But electrolytes, when you have a person with very high lipids, for example, or proteins, these electrolytes are not found in lipids, in the lipid part, okay? But the lipid part is occupying a lot of volume. Whether it's a lipid or the protein, it's occupying a lot of volume. So this water part here is not 100 microliters. It might become, let's say, just an estimate, let's say 70 microliters. Okay, so the analyzer is going to measure only what's in this 70 microliters, not in that 100 microliters. Okay, so because of this, the value of these electrolytes can go down. Okay, so that's called, it's called a pseudo. This is a pseudo hypo, let's say the value was for potassium kalemia. Okay, so this is simply because electrolytes are found only in the water part, and the presence of these large lipid particles or protein particles occupy space, and the amount of water will be less. So we're injecting less into the analyzer, and we're going to have this pseudo values. This is something due to the situation in the lab. Potassium analysis, once again, among these electrolytes, one of the most important analysis is potassium is one of the top 10 tests that is done in a clinical setting. So hyperkalemia, high potassium, hyperkalemia. Okay, hyperkalemia. This is a potentially life-threatening situation, and it really requires a accurate analysis of what's the actual cause that's leading to the high potassium. Is it due to a metabolic reason in the body? Is it due to an iatrogenic reason, something from the outside? Okay, or is it due to the lab processing problem? Okay, so once again, we have a pseudo situation here, something due to the fact that we have to take the blood sample. So when we collect a blood sample, so we collect a blood sample, and then if the blood is allowed to clot, okay, if there is clotting, then after centrifuging, we spin the blood sample, and then we get the serum. Okay, now if we don't allow the blood to clot and we centrifuge, then the cells and all go at the bottom. Same thing here, the cells, the red blood cells and white blood cells go at the bottom, and then we get the plasma. Okay, so serum and plasma. Serum is the most common liquid that is used for measuring various chemicals. So plasma is less frequently used. So what happens is during collection, so during blood collection or during the preparation of the serum, whether it's the centrifugation or even the clotting, red blood cells can lyse. And red blood cells, like any other cells, have very high potassium inside. And when some red blood cells break down, they release the potassium into the serum. And that's going to give you a very high potassium. Okay, so that's one possible reason of getting high potassium. That's due to a lab situation. Then we have patients who have very high platelets. Okay, patients who have thrombocytosis, or patients who have very high WBCs, leukocytosis. Once again, these white blood cells or platelets, when they are present in very high amounts, and these platelets and white blood cells break, either during blood collection or during serum preparation, they are going to release potassium. Okay, and in case of clotting, okay, during the clotting process, potassium is also released. Okay, so potassium is also released during clotting. Okay, so not only does lysis release potassium, but the actual clotting, and the clotting happens when we make serum, when we take whole blood and we make it to serum. Remember, we allow the blood to clot. Okay, we allow the blood to clot. And this clotting process is also going to release a lot of potassium, leading to hyperkalemia. Okay, so if the clinician suspects that he or she may be getting this high potassium because of the clotting, then one alternative is, instead of using serum, we just use plasma to do the test. Okay, so these are some of the conditions that you have to keep in mind as a healthcare professional, especially for potassium. Okay, potassium values are not very high, normal potassium values. So potassium can be affected quite seriously by these kinds of lab-related errors. Okay, these are the lab-related errors. So that's why we call them pseudo hyperkalemia, pseudo hyperkalemia. Okay, so that is all for now for electrolytes. We will see you in the next video.